talk about stories as we think about the integration between mental health services and chaplain services. Stories are important as we think about who we are as providers and how the care that we provide to the veterans and service members fits into a narrative. We tell ourselves narratives about how the care we provide contributes to the health and wellness of our patients. And in our different fields of mental health and chaplaincy, we've approached stories differently over the past 70 or 80 years. And I think by exploring these differences, we can think about the strengths and potential weaknesses of both our disciplines in a way that ultimately brings us to a place of providing patient-centered care that brings the best of what scientific mental health care approaches put on the table, as well as what approaches within chaplaincy can bring to the care of our veterans and service members. We think in stories, and we're taught from a very early age to do this. For anyone who's been a parent of a young child, you can think about what is a young child's favorite question? Why? And why do children ask this question so frequently? They're trying to construct stories that tell them about how the world is constructed, about who they are in the world, and about how they should behave. We call folks who expect good stories optimists. And optimists are likely to have a range of better outcomes in their lives. Their immune systems are even stronger than the rest of us, and they tend to live longer. Believing good stories is powerful and allows us to live into those kinds of stories. Now, there's a flip side to stories. Stories can also be profoundly destructive and dangerous. Many could argue that the most important event of the 20th century was World War II and the Holocaust. And this, of course, caused humanity to ask many probing questions of itself that we asked in lots of different ways. You may remember Stanley Milgram's famous shock experiments, where Milgram was really trying to answer the question, could Americans behave in the same way? Could the average person off the street be persuaded to tell themselves a story about how this was okay?
Under what conditions would a person obey authority who commanded actions that went against conscience?
The victim, according to plan, provided many wrong answers. His verbal responses were standardized on tape, and each protest was coordinated to a particular voltage level on the shock generator.
That is incorrect. This one will be 195. This will be at 330.
Now, what Milgram concluded is that you could easily get a large proportion of average individuals who, when instructed by an authority figure, could do something that they never thought they would do under normal circumstances.
Let me out of here. Let me out.
Continue, please.
Let me out of here. My eyes bothering me.
Go on.
Let me out.
Experiments like Stanley Milgram's represent a larger movement within psychology where we really became consumed examining all the different ways that we as human beings deceive ourselves with the kinds of stories that we tell. A major way that we looked at this has been termed cognitive bias research. One of the most popularly known biases is hindsight bias. Simply put, hindsight bias is being more confident that you would have known an outcome once you actually know the outcome. We see this often in how people interpret science. So folks will frequently say, oh, I can't believe we spent another $1 million or $2 million to find what I easily could have told you would be the result. As another example of one of the cognitive biases that we're prone to, I invite you to take a second and consider the story of Steve and think about whether it's more likely that he's a librarian or a farmer. You probably guessed that Steve is a librarian. The reason why Steve is in fact more likely to be a farmer than a librarian is because for every single librarian, there are approximately 20 farmers. You were asked to think that Steve was selected at random from a representative sample. So it's more likely that at least 3 or 4 of these farmers are going to have characteristics of being shy and withdrawn and seeming like a librarian than it is that we randomly happened upon the one librarian that exists for every 20 farmers in the population. So this error is called the base rate fallacy. And there are a number of errors like this that illustrate how we as human beings are not inherently good statisticians. Yes, in fact, we are susceptible to many of these cognitive biases. We're susceptible to things like the recency effect. The recency effect being that as clinicians, we tend to remember the most recent patient that we saw and think that that patient was more representative than in fact they are. We're also susceptible to something called confirmation bias, which means that we tend to look for the places where our treatment has worked and discount the cases where it hasn't worked. We end up using a treatment that may not be as effective as it feels like to us because of confirmation bias. In addition to that, we're susceptible to a number of different statistical biases. Patients tend to come see us when they're at their worst. When people are at their worst, they tend to get better automatically to an extent because there's no other direction to go. As clinicians, we can begin to tell ourselves a story that our treatment is what is contributing to a patient's improvement, when in fact, some of that improvement may have happened without us. One of the significant players around the time that clinicians were grappling with the extent to which evidence should inform their clinical care was Paul Meehl. In 1954, he came out with a book entitled Clinical versus Statistical Prediction. And in this book, Meehl demonstrated we do a better job of predicting our patient's behavior when we use data instead of using our expert clinical judgment. And over time, Meehl has been categorized, I think, somewhat unfairly as relying solely on data when we think about the care of our patients. Meehl, in fact, pointed out on a number of occasions that we should use data when data are available. But data are often not available when we're conducting clinical care. For large systems like the Department of Veterans Affairs and Department of Defense, they need to make large-scale utilitarian decisions about their patient populations. And scientific healthcare, as epitomized in randomized controlled trials, can tell us about the sorts of decisions that we need to be making at a large level. By using a randomized controlled trial approach, we can see if newer treatments are more effective than existing evidence-based treatments. It allows us to take our best guess at what sort of treatment is most likely to be effective for the individual that's sitting in front of us. And finally, scientific approaches to healthcare also help us test treatments that we suspect may not be efficacious. Scientific approaches to care and the way that we set up randomized controlled trials tells us about the average patient. But there's a lot of variability within these trials. Within that variability, there are lots of different patient stories. There are ways that we can handle some of that variability from a scientific vantage point. But at the same time, relying solely on this approach to understanding our patients can sometimes lead us to a place where we may not know what to do with the patient who doesn't improve. And we may become overly dogmatic in how we think about alternative ways to to approaching patient suffering, what really underlies our thinking about evidence is what we consider appropriate outcomes. We often term that our dependent variable. So in trials where we're looking at depression or PTSD, our dependent variable, understandably, is the amount of depression or amount of PTSD that a given patient is experiencing at the beginning of a trial and then is experiencing at the end of a trial as a result of receiving the intervention. Outcome variables are an important place for us to consider whether there are other outcomes that are important in the lives of our veterans and service members. Of course, we want to help reduce their suffering, but as we invite chaplains into conversation with mental health care providers, might we also want to think more broadly about what it means for veterans and service members to live lives that are meaningful and valuable for them? Might we want to think beyond just measures of depression and PTSD to thinking about other ways that we might conceptualize the fullness and richness of what it means to live a flourishing life?
I'd like to just briefly go through treatment with an individual, a Vietnam vet, who came back from Vietnam, had a number of traumatic experiences, and one in particular that involved a bunch of dead bodies that troubled him. And because he was married and had kids, and he had to find another job after he left the military, after he returned to the States, that need to accomplish those things sort of kept him going. He was still troubled. He still had a lot of nightmares. He still would wake up in the middle of the night with intrusive thoughts and memories of these events. But once his kids grew up and left home, and then it got to the point where he no longer needed to work, he was up in years, his PTSD symptoms got much worse. And it got to the point where he couldn't even sleep at all. And it got so bad that his wife basically gave him an ultimatum: if you don't seek help, I'm leaving you. So, he was desperate. His symptoms were severe. His wife was going to leave him. His kids were gone. So under those dire circumstances, he sought treatment. And when I saw him, I asked him what he did anytime he had these painful recollections of these events, and this one event in particular, again, involving lots of dead bodies. And he said he did everything he could to push them out of his mind. And I asked him, well, would you consider it an alternate approach? And he looked at me in a weird way, but he didn't say no. And I suggested to him, well, how about if we do this? How about if you tell me a place you like to relax, and in a little bit you close your eyes and you imagine being there, and then when you're feeling relaxed, you will see yourself go into a very comfortable movie theater, and it has very comfortable seats, and you'll find a seat that you'll sit down in, and after you're there comfortably seated, you'll see a remote control, and when you're ready, you'll press play, and the goal will be for you to watch that entire horrible event involving a bunch of dead bodies from beginning to end, in however much detail is necessary in order for you to heal from it. And you'll have total control over this, and because you can hit stop, you can hit pause, you can fast forward, you can reverse it, you can control the volume, you can even control whether the picture is in color or black and white. But the goal of this will be for you to make it through the entire event from beginning to end in however much detail is necessary in order to heal from it. So he agreed to do this. And he was able to relax a little bit. He was still somewhat agitated, but he relaxed a little bit, had his eyes closed, imagined the theater, walked into the theater, found a comfortable seat to sit, saw the remote control, and when he was ready, he pushed play. And the moment he pushed play, he turned red, He just had intense emotion, and then he started describing the scene out loud to me. And it was a struggle for him. You know, he stuttered, he coughed, he, was very emotional during it, but he managed to watch the whole scene from the beginning to the end. And when it was over, I asked him if he would get up from his seat in the theater and walk down the aisle and walk into the movie screen and say whatever he wanted to say to his younger self that went through that horrible event decades ago. And he went like this when he did that, telling me that he was actually hugging himself. And he didn't describe in great detail what he said, but you could see an incredibly sigh of relief, and his body was more relaxed than before, and then he opened his eyes and we talked about what happened. And that night, he slept incredibly well.
Narrative medicine is to take med students who are training to become interns, residents, and attendings, that if they want to care for the sick as doctors, they must understand that there's more than just diagnostic codes that we put in the computer for Medicare and Medicaid billing. The care of the sick unfolds in stories. The effective practice of healthcare requires the ability of the doctors, and I would also say the chaplains, to recognize, absorb, interpret, and act on the stories and plights of others.
The approach that a chaplain takes when talking to a veteran isn't like many disciplines where you have to ask questions and get answers in order to justify a diagnosis. A chaplain purposely will take a more holistic view and a more patient-centered view. They will ask the veteran, "Hello, Don, how are you doing?" to establish a dialogue and then give the veteran an opportunity to share their story, a human living document, if you will, of who that person is and what that person's about.
Narrative competence is a model not just for what is called logico-scientific medicine, but a model for humane and effective medical practice. It addresses the need of patients and their caregivers to voice their experience, to be heard and to be valued. And it acknowledges the power of narrative to change the way care is given and care is received. What are the elements of narrative competence? Narrative is a source of information that goes beyond the diagnostic differential diagnosis. So narrative is a source of information, but narrative is also an instrument of knowledge, where the doctor and indeed the chaplain see the patient in front of them as a story unfolding before their very eyes.
While the veteran is sharing that story, the chaplain is thinking of what is the lament, what is the most important thing that that veteran is sharing that would give some clue or some indicator of where the chaplain needs to focus the attention. So the story becomes the paramount interaction each time a chaplain visits with a veteran.
Narrative competence serves professional functions beyond the treatment of illness. I mean beyond the physical aspects of the disease. Narrative competence inspires trust between doctor and patient to promote empathy and relationship and connection between the physician and the patient.
Sometimes A combat soldier or Marine will hold on to things. They will not readily share. They've learned long ago to take that information and put it to sleep. And as long as they don't deal with it, it won't hurt them. But as a trust level develops, it becomes easier and easier to share with another individual who I believe understands what I'm going through, who I believe will be there to help me and not try to medicate or not try to, tell me what I should be feeling.
It is indispensable for the professional use of narrative that it finds a clear illustration in the concept of narrative situation. A narrative situation shapes every story by governing who speaks and what is that story about and to whom they're telling the story and at what time and where they are telling the story. The meaning of any narrative must be judged in the light of its narrative situation. And these are the questions that we should ask ourselves. Who is telling it? Who is hearing the story? And why and how is it told?
That's the beauty of listening to the veteran's story, because everything you're getting from that story is coming from the veteran. And you don't have to edit it, you don't have to change it, you don't have to manipulate it to make it fit a particular diagnosis. So for a chaplain, that veteran story is probably the most important part of pastoral care that can be provided. And it gives the veteran the opportunity to share what they want to talk about, not necessarily answer the questions that a clinician wants to talk about.
When the doctor meets the patient in the exam room and is ready to listen to the heart with the stethoscope and to auscultate and to percuss the chest and to get the pulse and all of that we have in physical examinations, there is more or should be more that is happening between the caregiver and the patient. And that is the relationality between two persons in that exam room. Narrative discourse is someone telling someone else that something happened, emphasizing narrative's requirement for a teller and a listener, a writer and a reader, a chaplain or a physician or a nurse or a social worker with a patient, and most importantly, a communion of some sort between the two. Ultimately, narrative medicine and narrative chaplaincy both utterly depend on the concept of intersubjectivity. Narrative considerations probe the intersubjective domains of human knowledge and activity. That is to say, those aspects of life that are enacted in the relation between two persons. The narratively competent reader or listener realizes that the meaning of any narrative, instead of being monolithic and hierarchically given, meaning from the top down, meaning is apprehended collaboratively by the reader and the writer, the observer and the observed, the physician and the patient, the chaplain and the patient. And we've heard a lot about patient-centered care. It's no longer the physician being the knower of medical expertise. The patient is the center of our focus, and medical decisions and treatment decisions have to be made in a shared way, which is called shared decision-making. How do chaplains hear, or how should they hear and understand patient stories? Clinical Pastoral Education, or CPE, pays close attention to illness stories surfaced through intersubjective encounter between the chaplain and the patient. And all chaplains who have gone through the CPE process know that one of the elemental aspects of CPE is writing verbatims. The verbatim is a major educational experience in CPE. Verbatim seminars involve a student in CPE presenting a pastoral encounter, or what we might call the narrative, to other students and the CPE supervisor for discussion, both with affirmation and critique. When I say verbatim, I don't mean that the CPE student is a stenographer. It is not literally every word that came out from the patient's mouth, from the chaplain's mouth, and from the family's mouth. The verbatim is the subjective presentation of the visit by the chaplain to the patient, and how the chaplain remembers what was said and what the issues were, and writing it up.
So that when I go back to the interdisciplinary team, I can go back and say, this is what I learned from the veteran at this time. Even though he's here for PTSD or depression, he's really focused on this issue, which may be something completely different than what that person was admitted for.
What do our different religious traditions offer to us in understanding patient stories? Since I'm a rabbi, I am most familiar with the Jewish tradition. So I want to talk a little bit about Midrash. Midrash is the body of homiletic stories told by Jewish rabbinic sages to explain passages in the Tanakh. Tanakh is the Hebrew scriptures, which is the 5 books of Moses, the prophets, and the hagiographers. Midrash goes beyond the surface of the words. It looks and fills in the gaps left in the biblical narrative regarding events and personalities that are only hinted at. So let me give you an example of a midrashic illness story. There is a tradition that dates back to the Talmud that there was no sickness in the world before Jacob became sick. A midrash retells the story of Jacob's illness. And the midrash says, from the day the heavens and earth were created, a person was never ill before they died. When a person's time came, he or she would spread out on the bed and their soul would depart. No pain, no suffering, no medications, just lying back and dying peacefully, like a whisper. But Jacob said to the Holy One, blessed be He, Master of the universe, it isn't good that a person doesn't feel anything before their death. People aren't careful to write a will, to speak their final words to their children and family, that is, leaving a legacy of meaning, what my life was all about and what heritage I can pass on to my children, grandchildren, and to future generations. So Jacob said, "Thus I pray of you, Lord, let people become ill and feel that their days are numbered, so that they will be quick to speak with their families and to give over to them their final wishes." And this is what we who work in hospice and palliative care say, unfinished business. What was God's answer? The Holy Blessed One replied to Jacob, "Your request is a worthy one, and I will begin with you." Thus, our father Jacob was the first one to fall ill. And then he was able to gather the different generations that would come after him and give each child a message tailored to that particular child.
In the 1950s, Corrie ten Boom, a Dutch Christian who was jailed for helping Jews escape Nazi-occupied Germany during World War II, visited the Dutch Reformed Church where my grandfather was the minister, and it had an influence on my uncle who was there and who went on years later to track down 3 different survivors of what was called the Kinderlager. It was a section of Auschwitz where the children were held. And his purpose in tracking down these women was to help them tell their stories. And these women, understandably, some of them were conflicted about telling their stories and felt like, do I really want to do this? What's my motivation for telling this story? And on the dedication page, each one of these 3 women who ultimately did decide to tell their stories provided a reason for why they did it. And one of the survivors of this Kinderlager writes this dedication. She says, "In memory of my sister, my grandparents, aunts, cousins, friends, teachers, and the destroyed world of my childhood, and in the hope that such tragedies and traumas still happening can be stopped and that no child will experience them again. Let that be the world's future work." And as a clinical psychologist, when I went back and looked at this dedication and this motivation for Frida Tenbaum to tell her story, it struck me that it's so important for us to realize that the veterans and service members who are coming to us with their stories of trauma, with what we sometimes call in clinical psychology trauma narratives, for us to think about why are they bringing these stories to us. And we've made a number of advances in clinical psychology to approach these trauma narratives in a way that can lead to healing for veterans and service members. And when we talk about healing, we're often talking about a reduction in PTSD symptoms. And that's excellent. But can we also think more largely about these stories and the motivations of veterans and service members who are bringing us their stories? Can we think about what it means for them to bring their stories to us in memory of whoever it is, whoever they may have lost as part of their war experiences, or in memory of a time in their life or a person who they used to be? What does it mean for us to handle their stories in a way that we can honor that memory? And what does it mean for us to think about how we can also hear their stories in a way that brings hope? And to realize that they tell their stories so that they can bring hope, not only to themselves, but possibly to others.
I would like to share a brief story with you. It's a story about a young man that I was involved in the care of this young man while he was hospitalized. And I hope this story helps to illustrate for you some of the aspects of narrative medicine, pastoral care, and the synergy and effectiveness that might be the outcome of good communication and collaboration between the different disciplines and providers as they consider the story that they've learned about this particular individual. A few years ago, I met an intelligent young man who had been admitted to the hospital. He was coming in for tests regarding some symptoms that indicated that he may have cancer. The test did prove that cancer was in the bone of his upper thigh, and it seemed that the best course of action at that time was at least one surgery and ongoing treatment. He remained somewhat optimistic about it. When I met him, his mother was at his side, who remained steadfast throughout his care during the time that I knew him. And she had traveled over halfway across the country to be with her son, who was in his mid-20s. And she gave him a lot of comfort. It was apparent that as she was there in the room with him, that he felt less alone and that it gave him some comfort. She was limited in her ability to communicate with the medical providers as well as myself because of her difficulty in speaking English. One of the things that I learned early on, that while she gave him comfort during his care, what really seemed to make the difference for him is when someone from his unit that he was serving with in Iraq before he was admitted to the hospital, when someone would make contact with him, or the occasional but not frequent visitation by somebody from his unit, it seemed that really brought a lot of light into the room and a lot of life in him, and a sense of relief and connectedness that was missing. In my initial conversations with this young man, I learned that he had been raised in a Catholic family, but he was now exploring other faiths, including Buddhism. He hadn't really landed anywhere, but it seemed that he was forming new questions that might help him decide about what religious or spiritual teachings and practices that he would want to employ in his life. He also indicated that right now, in the moment of dealing with the newly discovered cancer and all the dynamics of being separated from his unit and his sense of really not having much control about his fate at the moment, it didn't seem like the best time for him to explore that avenue of spirituality, yet it was on his mind, and he shared quite openly about that. The expectation was that the treatment that he was going to receive was going to involve some surgery, of course, and then hopefully after a little bit of treatment be discharged and he would go back into his normal routine in life. Instead of the brief kind of surgery and treatment that he had hoped for, he ended up having multiple surgeries. They began with an amputation of his leg, and as he was beginning to recover from that, further tests revealed that they had not been successful at removing all of the cancerous cells, and the radiation and chemotherapy did not seem like a conclusive way to really rid him of the cancer. So further surgeries occurred until he had begun to lose a good portion of his hip, where now he was looking at a much more complex recovery, many more complications in his life medically. Prosthesis was not really available to be able to replace that much of what he had lost. And so there were lots of complications that came into play. Depression became a part of his life, anger, a sense of being out of control, a loss of hope. And we reached a point to where the pain management team was listening to him, but in his constant pain and their striving to respond to that, they had reached a point where all of the medications that were at their disposal and the level of dosage that they could safely provide had been exhausted. The oncologist was running out of options. The orthopedic surgeons were frustrated because they felt so badly for him, but yet they continually were forced into a situation where it was very difficult to really provide him the kind of solutions that anyone would want in his state. And from my perspective as a pastoral caregiver, I could only hope that my continual visiting, my continual listening, the times that we spent together in silence, the prayers that were offered, that they would in some way give him a glimpse or a vision of hope in the midst of very, very difficult circumstances. The social worker was working diligently to make sure that his mother was supported during this difficult time with all of the challenges that come when there are language barriers during medical care. With the financial restraints that she had, she was a woman of very modest means, and there was much that had to be done socially, both for the patient and his family, so that the greatest source of comfort that he had, so that they would be supported. So you had all of these different disciplines, all of these different providers that were listening to his story and trying to come up with the best solution for his care. What was interesting is while some of those providers would cross each other's paths during the course of the day, and they might mention his case to one another and share some knowledge, the entire team had not assembled and discussed at any length their understanding of his story. What happened is when push came to shove and we were all running out of options, and the patient had reached a point where he had been hospitalized so long that he had kind of, by observation, I'm sure some of you have seen this type of occurrence, he had really learned how the system worked and how the providers, the nurses and the staff on his floor, how they functioned and what perhaps may even be their buttons to push. Well, when you're totally out of control, you don't feel like there's anything in your life that you can manage very well, and your hope is dashed, it's very easy to fall to the temptation to begin to manipulate people in your anger. So he began to test the nurses. Nurses that he once had a very cordial and friendly relationship with, now he was becoming very demanding and quite angry towards them, to where even staff reassignments had to be made. There were some real challenges because he was starting to act out of his frustration and sense of helplessness. So we decided it was time, that we had reached a wall of options, and now we needed to assemble and figure out what was the next best step. So we all agreed to allocate an hour. The mental health provider, the social worker, the oncology team, the pain management team, the orthopedic surgeons, myself, we all got together and we sat down and began to share with one another what we had heard from this person and the story that we had learned. And it was different from each person. Certainly there was commonality throughout all of them. But the reality is that patient was sharing with each of us what he thought we would want to know based on why we were there. His interpretation. Why is the chaplain here? What would he want to hear? What would be helpful to him and helpful to me? And on through the various different disciplines. So we each heard a little different version of his story, but when we came together and we were able to compare notes, we assembled a much more comprehensive story. And I think probably a more honest and truthful story about what was going on with him and what would truly be the course of action that would acknowledge and respond to what his values were, what his beliefs were about, where he was emotionally and physically, and truly what is most meaningful to him in his life. At this point, I really believe he had already written the last chapter of his story. I think he was pretty much without hope and didn't have a vision for what life could be somewhere down the road. I think it was just survival at this point. But by assembling his story and coming up with a more comprehensive picture, by sharing our knowledge with one another, we were able as a team to actually put into place what I think became the most optimal outcome in his mind as well as ours, in considering his medical, his psychological, and his spiritual health. It seemed to make the most sense to get him back home as safely as possible, to arrange for good living conditions in his home back home, and to set it up to where he could be surrounded by his loved ones, the people that he knew, his friends, and even be closer to his unit command headquarters so that it would be easier for those he served with to come and visit him when they could. So those arrangements were made, and while there was a considerable amount of work that was performed by the social worker to coordinate that, she did so with all of the other providers. And also, at the end of the day, probably the most moving part for me, the evidence that he gave to me the day before he was discharged, is when he told me he had enrolled in 2 college courses at the suggestion of the social worker, which told me that the result of us all getting together and sharing the stories that we had learned to build that comprehensive human story about this individual gave us the information we need to where now I believe the last chapter to his book, of his story, is much more open, and he is more open to the possibilities and the options that may be there for him to live in the midst of his suffering. We couldn't end the suffering, but maybe we did something to help contribute to his ability to live.